We're continuing our discussion of diagnosis in Lacanian psychoanalysis. This is our second session in that series of talks, and we have entitled it Clinical Structures. We ended the last lecture by stressing the importance of looking to structure and not simply being satisfied with an indication of symptoms. We can build on that point by saying here that what's really important from a Lacanian standpoint is that when certain symptoms are evinced, are brought to the session, one doesn't just stop there and say, well, there's the symptom that gives us a diagnosis, but what one needs to then do is to ask the subject about their relationship to that symptom. I've tried to note that here on our chalkboard by saying the relationship to symptoms should be explored in a great amount of detail. And I've even used this word phenomenological here because often psychoanalysis and Lacanian psychoanalysis in particular is seen as opposed to a kind of phenomenological exploration of subjective meaning. That may be the case in certain situations, but I think here it's fully justified that we do as much detailed exploration of the subject's experience of their symptoms, of their relationship to the symptoms, and of the meaning they start to make of their symptoms. The more that exploration is developed, the more we will find that, for example, a subject who vacillates and has a great deal of doubt about the hallucinatory moment has a different relationship to that symptom than someone who takes the hallucinatory moment as certain, as absolute truth, as a commandment telling them to do something. Already there, we start to get a sense between a separation between neurotic as opposed to psychotic structure. So the exploration of the subject's relationship to the symptom and their experience of the symptom must be fine-grained, detailed, extended work. And it's that way, that's one of the many ways that we can get to try to appreciate structure. And I've reiterated that again here as well. Structure could be understood as the subject's mode of being in the world. And the reason I put that there like that is to stress that you can't extract someone's structure from them. And in Lacanian psychoanalysis, particularly early Lacan, you cannot change structures. So let's also just foreground that point right now. One of the reasons that there are structures and a structural diagnostic system is both because the structures come before the subject, in a sense, are defining of what the subject is, constitutive of how the subject in fact is a subject, but also because one cannot move, one cannot become psychotic if one is neurotic. One cannot become neurotic if one is psychotic. So just to keep that mutually exclusive approach to structures in place. Now, I've put in a whole bunch of points on the board here, and it looks like we're not doing them in order, unfortunately. But the fifth point that I wanted to note, and I wanted to just speak about this before we come back to this three-part structural system and also develop some critiques and questions. The fifth point that I noted here is that the notion of abnormality has no place in psychoanalysis. I remember Bruce Fink making this point very clearly in his A Clinical Introduction to Freud. Very straightforwardly, unequivocally, he stresses that from a Lacanian perspective, the concept of abnormality has no place within the clinic. This is really important, and I think it has crucial political implications. It also has a knock-on impact in terms of how we even think about the whole domain of psychopathology within Lacanian psychoanalysis. And maybe the immediate answer here is to say that the notion of psychopathological perhaps doesn't fit so well within a Lacanian frame. That doesn't deny that individuals have certain modes of suffering, doesn't deny the idea that there may be subjective structures of the kind that we're articulating. But often, when we have the domain, or when we have reference to, or within the psychiatric subdiscipline of psychopathology, we have a problem. We have a crucial political problem, and a problem of norms that Michel Foucault has already kind of alerted us to. And this is the problem. How do you define what is pathological as opposed to what is not pathological? And in the domain of the psychological and the psychiatric, you could say historically, there are many types of subjective disposition, types of subjective sexuality, types of suffering in the world that are understood as psychopathological, predominantly because they can be characterized as departing from a norm. They can be characterized as abnormal. The Lacanian approach is to say that if we're going to even use this notion of psychopathology, which doesn't really fit all that well actually within a Lacanian frame, but if we are going to think about pathological, and Freud does this a little bit, he's clear the way one stresses or the way one thinks about the pathological, the psychopathological, is not because it departs from the norm. And one can appreciate why that position is problematic. In other words, the position of thinking about psychopathological and defining the psychopathological as abnormal. That's problematic because you don't have to go that many years back in the Diagnostical Statistical Manual to see homosexuality thought of as psychopathological because it deviates from a norm. So that's not the way to do it. For Freud at least, if one wants to try to pinpoint something that seems pathological, the way to do that, and the very way of understanding psychopathology, has got nothing to do with norms, it's got something to do with the suffering of the subject. In other words, you can well imagine a situation in the 1940s where there's a subject who is gay, who comes to the clinic, or a clinic, and the clinic thinks that he's abnormal. For Freud, that doesn't work. The clinic that this guy goes to thinks he's abnormal, thinks he's psychopathological, because that's not the political norm of the time. Homosexuality is not accepted. For Freud, though, we can imagine that someone comes to his clinic who evinces abnormal behavior that departs from the norm, but they're not suffering. They don't have a problematic relationship to being, for example, gay. But of course, the argument doesn't finish there. One can also imagine a situation where there's someone who grows up in a society which is okay and which is not homophobic, which is okay with being gay, who still finds something about their sexuality problematic. And therefore one can be thoroughly within the norm, so to speak, but still have a, as it were, a pathological relationship to that norm, or to one's own life, one's own sexual life within that norm. In other words, to cut a long story short, for Freud at least, if we're going to talk about psychopathology at all, it relates to the question of the person's suffering. And I think that's a nice shorthand idea to bear in mind. In the Lacanian clinic then, what's important is not notions of normality and abnormality, but how someone is suffering and how we're able to address and approach that. So let's then have a quick look at this schematic. This schematic we can add to, and you'll see, perhaps if you're familiar with these categories, that there's one or two differences to how it's normally approached. The basic schematic breakdown is simply this. The first mode of negation is repression. The first, as it were, structure is that of neurosis. Neurosis is typically broken down into hysteria and obsessional neurosis. Freud always being careful to say that obsessional neurosis is, as it were, a dialect of hysteria. So we've got hysteria and neurosis. Those are the two paradigmatic formations or variants of neurosis. You could make a few additions here. You could say, well, what about phobia? In the earlier tradition, and also in Bruce Fink's book, he includes phobia. You could do a little line here and add phobia. In my clinical experience and case studies that I've attended, phobia doesn't appear that much. And some people, as is the case with Sergio Benvenuto, this is a book of his, a recent book of his, Conversations with Lacan. He says, well, let's keep phobia in the general scheme, but maybe phobia fits more closely as a variant of hysteria rather than a sub-branch. But let's stick to the point here. The basic schematic is that neurosis is made up of hysteria and obsessionality. One little dotted line I've added here, just because a colleague of mine, Kristen Hennessy, who's a fantastic clinician, has suggested to me that sometimes in her own work, where she works with a great deal of people that are suffering from some or other traumatic situation, she's she did suggest that this might be one way of thinking about it. In other words, we could put that differently. In her words, you could say that maybe we could imagine another branch of neurosis, so we don't just have hysterical and obsessional neurosis, but we also have a traumatic neurosis. One could put that in another way and say this, that if one is neurotically structured, one can be traumatized, but how one is traumatized will be within the terms of one's neurotic structure. So before going on then, let's just say that one can imagine, one of the questions people sometimes have is like, where's depression? And the Lacanian answer is the reason depression is not more apparent here is that you can be depressed in any of these structures. The same goes for narcissism. In some psychodynamic and some psychoanalytical diagnostic systems, narcissism is very important. But for Lacan, neither narcissism nor depression nor the notion of borderline, those things simply do not attain, as it were, the dignity of a differential diagnostic. In other words, they don't adequately differentiate. They could be apparent. You can be depressed in any of these structures. You can be narcissistic, or you can have a narcissistic appearance, personality in any of these structures. Lacan's not denying that. He's just saying that they don't attain, as it were, the dignity of a properly differential diagnostic concept. Let's move on to psychosis then. Schizophrenia is probably the term that most of us are most familiar with when we start to think about psychosis. But importantly for Lacan, melancholia, what some other diagnostic systems may in fact refer to as psychotic depression, is another category of psychosis. There's also paranoia. And if we had to refer back to Sergio Benvenuto, he would argue that paranoia can be broken down into a whole sub-variety of different types of paranoia. But the important point for here is that paranoia is one of the main three forms that are generally agreed upon, the three forms of psychosis in the Lacanian system. There's been some debate of late, hence the dotted line. Someone like Darian Leder has suggested, well, where would we locate bipolar? There's debates. He would argue that there's some arguments to say that it could belong here. Maybe other people would say that that doesn't necessarily have to be the case. Another very interesting area of research is autism. Sometimes there's Lacanians who think that autism is kind of necessarily a part of psychotic structure, but I also know colleagues who say differently. They say, again, autism could be apparent in any of the three structures. So there's debates about how one might consider situating autism. The domain of perversion, again, you could have more subcategories here, but the kind of subvariants of perversion that are generally recognized, certainly sadism, masochism, and fetishism. Sometimes people put voyeurism there, but again, these are the predominant instantiations within that fundamental structure of perversion. So that gives us a kind of schematic of those basic clinical structures, and that's kind of the main work we wanted to do in this talk. Let's just then, by way of conclusion, refer back to a debate that we started last time. Isn't there something problematic about such a categorical system? Isn't such a system essentially objectifying? This to me seems a really important question, and also one that has a kind of added irony, given that the more Lacan continues his work, he becomes absolutely opposed to many psychological conceptualizations that he thinks risk objectifying the subject, objectifying people, objectifying psychical structures. He has an almost allergic reaction to this. So if that's the case, one could say, well, surely this does the same. Different colleagues, Lacanians, might have different answers to this, but I will give two answers. I would say, one, that even though we might use this as the kind of rough background blueprint for how we situate our clinical work and how we think about various clinical manifestations of symptoms, of subjectivity, ultimately, your first ethical priority is not absolutely to the diagnostic frame. Your first ethical priority is to the singularity of the subject. If we wanted to put that in more dramatic terms, you could say that every subject who presents themselves at the clinic is singular, is unique. It's almost as if you could argue that with every person who presents themselves at the clinic, you have to rethink your diagnoses, because they're not going to simply be a straightforward representative of any of these things. So you could say that there's a tension here between the structural system with its categories and the attempt to be a science of the particular, to be a practice which is highly an attempt to be as attuned as possible to the singularity of a given subject who's not like any other subject. So this tension is sometimes somewhat difficult to manage. On the one hand, the priorities of structure. On the other hand, the attempt to highlight the singularity of the subject. One anecdotal point that I could make in this respect was that at certain points when I was undergoing facets of a psychoanalytic training, I remember being in supervision and my supervisor saying, you're talking about this case. You're talking about the session you had on Wednesday. Stop talking about structure. Tell me what was said. Tell me what they were doing. Tell me what they were speaking about. Tell me how they spoke about. Stop thinking in terms of structure. And this was kind of an eye-opening moment for me, because it was kind of saying that stuff is important, but leave it behind for the time being while you attend to what is being said, while you listen, while you attend to the singularity of the subject. So my response, I haven't seen this written, hopefully colleagues are making a similar kind of argument, but my response to the potential problems of objectification is twofold. One is to say that although we have this very important grid, this set of structures, ultimately one should bear in mind that there is an infinite amount of variation in terms of how anyone might be psychotic, or for that matter, how one might instantiate a kind of melancholia. There's an infinite amount of variation in terms of how someone might be obsessional, for example, or how one might be hysterical. But here's my really important argument. Ultimately, a structural system like this, a diagnostic system like this, is important to us not so we can pin a label to someone and say the psychotics who come to my clinic, the hysterics who come to my clinic, which admittedly is an unfortunate tendency in how these terms are used. Ultimately, those concepts, for me, are there to direct a treatment, not to be pinned as labels onto individuals. Maybe that's a slightly idealistic claim, maybe it's one we can only hope to see instantiated, but let's just reiterate that again as by way of conclusion. For me, the importance of this structural system is that it gives us a map, an orientation, a sensibility of what techniques and what type of clinical work is going to work with someone. It's not about pinpointing, labeling them or objectifying them. Let's stop there.